Hello, everybody, dear colleagues, dear panelists and participants. I would like to welcome all of you in front of Croatian Endovascular Initiative at the beginning of our regional webinar, Aortic Interventions during COVID-19 pandemic. We are witnessing significant problems in the world's healthcare systems in the last 2.5 months as a result of pandemic, social distancing, isolation, and the lockdown of the economy. Therefore, our goal was to organize this webinar to discuss with colleagues in the region the problems in aortic interventions over the past time and what await us in the near future. I would particularly highlight the problems in the organization of hospital systems, but also the phenomenon of the disappearance of patients with triple A rupture, for example. Now I invite our Croatian Endovascular Initiative duo, General Secretary, Assistant Professor Stambuk, and Dr. Krčmar, Vice President of HEVI, to take over the moderations with this webinar, and I wish to all of you successful and fruitful webinar. Can you hear us? Hello? Krešo?
Hello.
Tomislav? Hello, Tomislav? Hello?
Hello.
Hello,
Welcome
hello.
all participants. Hi, guys.
Hi.
Hi. Thank you, Dražen, for very kind introduction. Today we have 6 great speakers. I think it will be very interesting. Just a second, just to show you some things in the beginning. We have 6 great speakers. Thank you all of them for participating in today's webinar. I think it will be very interesting. Thank you all viewers to participate in our webinar today. I think we have a great audience for all the region and maybe even more. In the beginning, I would like to encourage all viewers to actively participate in webinar through asking questions. In any point of webinar, we encourage you to click on this icon in the bottom of your screen, Q&A icon, and you can write down any question you like. We will try to answer as much as possible according to our time limit. And we must continue with our webinar very quickly. I would like first to introduce my dear colleague and my great friend, Dr. Tomolic from University Hospital of Rijeka. He's a CAT lab chief, and he's also director of endovascular program in University Hospital of Rijeka. Vjeko, please, could you start and tell us how did you in Rijeka organize aortic intervention in COVID-19 pandemic era?
Hi everybody, dear colleagues, dear friends. Director of what? Endovascular, he said. That sounds so bold. So, how we organized aortic interventions during this unfortunate era? We didn't treat our patients differently than normal. Meaning we tried to, at the beginning of all of these epidemics, we tried to be as normal as possible and treat everybody with acute coronary syndrome, acute aortic syndrome, and of course cerebrovascular with stroke, all patients equally, and give them a chance to be treated as nothing was happening. The other thing was that at the beginning, we decided to treat everything as is possible with endovascular approach, because then we can spare some ICU resources, of course, and leave them for the patients that we expected to have. Fortunately, we didn't have so much critically ill patients who needed respiratory support. So we followed strictly hospital recommendations and implemented all these recommendations as they were presented to us. We restocked immediately with our implantable materials and equipment because we expected a serious supply chain and delivery disturbance. And that was done at the early days of March already. So we restocked, and actually this was, we now have, even now, we have everything for the next 6 months, I think, from this implant material side. We conducted some training, and these trainings were done regularly, daily, for the PPE, for personal protection equipment, for the gowns, for the masks, for the eyeglasses and everything else, and all the personnel has participated in that. And we encouraged an educative and the cooperation between all the nurses and the doctors and everybody else to have the protocols, as you can see them here, written and implemented. We try to, that they are something that can be implemented in daily life, not too complex, not too something that cannot be done by an ordinary doctor or nurse. And so we had we have these protocols for all these things, for the admission, for patient transportation, for cath lab conduct, intervention particularities, all specific interventions. So the thing was that we try to keep it simple, and maximum of 3 people in the cath lab were allowed, even for the acute coronary syndrome cases. And we try to do it on all our patients, if possible, with no anesthesia or without OT intubation, because as you know, this is the maximum risk situation for the COVID patient. This is our setting. Usually we have 3 cath labs, and the thing is that the interventional radiology also moved to our cath lab A, because their interventional suite is broken, and I don't think that it will be fixed soon. So we built a temporary wall here, meaning that the cath lab A was physically divided and from the rest of our interventional suite area. And this was unfortunately the only way in and out, because we didn't have any other way, because these walls were to the other ward, and this is the outer wall of the hospital. And meaning that the patient went in through here and went out through there. And the projected time for the patient to be in this cath lab was out of the order or use after the intervention was about 2.5 hours, because because of the cleaning and because we had to wait everything to settle down. We did all that, and at the end there was no COVID-19 positive patient treated for the acute aortic syndrome, even for these semi-elective cases for the aortic aneurysms. So we didn't have to do anything with those. We had some suspected acute coronary syndrome patients, but luckily none of them proved to be positive. My 5 minutes is up. Thank you.
Thank you, Vjeko, for the interesting presentation. Actually, how many times did you put on all the gear necessary? How many times did you
personally or
with all the gear on yourself?
4 times.
4 times.
4 times.
Yeah, we had luck, but no aortic intervention in this setting, right?
No, right. No, there are the other panelists will talk about that. I think Igor has a nice presentation about it. There are
Okay.
no EVAR or TVAR patients.
Okay, thank you, Vjeko. We will move forward, and now it's my great pleasure and honor to invite Professor Kuhelj. He is one of the leader in endovascular treatment in our region. He has a great experience and great knowledge and skills, particularly in the field of aortic intervention. And he will tell us what are the Slovenians' experiences with emergency EVAR-TEVAR during this pandemic. Professor Kuhelj, please give us a talk.
Thank you. Say that COVID has everywhere changed a lot our daily routine, especially privately. In hospital, I did not see that much problems. Last year, I'm coming from a big hospital. We had last year about 3,200 interventional procedures without neuro. We had about 800 neuro procedures. And I'm coming from a big hospital. We have more than 2,100 beds, about 8,300 employees, and only in radiology we have 270 employees. Last year we did more non-vascular procedures than vascular procedures. And if we are talking about EVAR and TEVAR, we did more than 130 procedures last year. So what were the conditions to admit elective patients during pandemic to my hospital? Patients should not have any signs of infections. We did not test all the patients for COVID. Patients without symptoms were not tested, and none of the TEVAR or EVAR patients we performed had positive, has been confirmed for COVID infection during the procedure. In terms of diagnostics, there was a huge reduction in CTAs and MRAs. We reduced it for approximately 2/3. This is outpatient. However, still there were patients who had emergency conditions and patients in whom prolonged diagnostics would negatively influence the outcome. Those patients were admitted. So this is 1/3 of the patients for diagnostics. For hospitalized patients, diagnostics was performed the whole time. And even in pandemics, in COVID epidemic, we had multidisciplinary meetings that were held once per week. The number of the staff at present was reduced, and of course, we changed some rooms due to be able to have proper distance. We used facial masks and so. If we go to EVARs and TEVARs, I compared our data in first 4.5 months. I compared specifically period from March 13 until May 13th, because this was the period when we had most patients and epidemics was on. I compared elective and emergency procedure. I have to say that during this period, there was 1/2 or 2/3 of the staff on hold. We were split it in teams, and if one team would get positive for infection, then the other team could come in. We have one radiologist and one resident who was positive for COVID. Radiologist was infected, his interventional radiologist. He was infected outside the hospital, and probably the resident got the infection from him. So these are the numbers. You see there is not much difference. If we put all together, last year in this period, we did 46 patients, and this year we did 41 patients. If we split it, there is a big change in emergency patients. However, these numbers are really small, and these patients come in boluses. So perhaps I'm not sure that this is really a reduction of emergency patients. Probably it's just inside statistical error. And in conclusion, I can say that there was a huge difference in imaging procedure. However, the impact of number of fever and TIVR procedures was minimal. We had less emergency procedures. However, the sample is really, really small. Basically, the patients were treated as they are usually treated. And the problem is that we treated some patients with COVID, not EVARs and TIVARs, but we had some patients. The problem is that working under the gear for hours is very, very difficult, because there is sweating, there is poor visibility due to the glasses you have to wear. And I'm really happy, and I hope we will not see COVID patients anymore in numbers like we had now. And this is one picture from Ljubljana, but this is pre-COVID area, pre-COVID time. I hope it will come back again. Ljubljana was really, really empty during COVID. Thank you.
Dimitri, thank you for the excellent presentation. I should say that we in Croatia had a significant reduction of the elective and urgent patients. The reason for reduction was, on the one side, that we decided not to do elective patients. And as I saw, you continued with your elective program, isn't it?
Yeah, you know, all the patients that are treated electively, they have large aneurysms. You know, they have like 6, 7, 8 centimeters, and these patients are waiting. Mostly we have waiting list about a month or two. And when they do diagnostics, they it takes probably 1 or 2 months to come to the multidisciplinary meeting. So I really think these patients were kind of not emergency, but probably waiting could really change their outcome. However, also we did not know how long this epidemic will go on.
Yes, well, we had yesterday one webinar and we talked about the indications, and we found a few different recommendations. It's clear when you have emergent patient with the dissection that you should do something. On the other side, if you have asymptomatic AAA with 55 millimeters in diameter, you can postpone this patient until the end of the COVID era. But all recommendations leave the gray zone of the indication. Do you agree?
Yes, 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 yes. You see, the numbers, however, are smaller than they were last year. Every year we are doing more and more procedures. So probably if there would not be COVID, we would anyhow have more patients that we performed now.
Okay, thank you. So before we proceed to another lecture, I would be pleased just to show 3 slides about 1 hour patient from Magdalena COVID era to hear what you think about this patient. So we have the male, 63 years old, and almost 30 years ago, this man had a chest trauma, and they diagnosed pseudoaneurysm of the aortic arch at that time, but they decided because of the size of the pseudoaneurysm not to do anything. After that, we discovered coronary artery disease, but in July last year, the diameter of pseudoaneurysm was almost 50 centimeters. And in the February this year, control MSCT showed the enlargement of this pseudoaneurysm for 12 millimeters. You can see here pseudoaneurysm of the arch very close to left subclavian artery. So this is the one of the slides that you see the neck of the pseudoaneurysm, and you see the sizes and the backward position of the pseudoaneurysm. So my question to you, Dimitri, to Vieko, and to other panelists is, what do you think about this indication? Because according to the recommendation, for instance, of the American Vascular Society, they recommend to postpone this patient for at least 30 days and to wait to see what is going to happen with the COVID situation. What do you think, guys?
How long was between the CTAs you showed?
7 months.
7?
Yes.
I think you could wait with this, 7 months. It was not a big increase, so perhaps you could wait. Okay,
Vieko, what do you think?
I think also that you can wait with this patient, probably.
Okay. Okay. During the session, we are going to see what happened with this patient. And now it's my pleasure to announce Dr. Igor Končar, friend of all of us, because he's helping us to do endovascular program with Eva for most centers in Croatia. So Igor, please tell us something, what's going on in Serbia, and what do you think, why did you lose so many urgent patients?
Hello, everyone. I hope you can hear me. Thank you for the invitation, and I'm glad to be part of this very nice initiative. On behalf of the Serbian Society for Cardiovascular Surgery, I wish you all the best. I also would like to congratulate to HEVI initiative in their activity during the COVID, but also in the pre-COVID era. And guys, I wish you all the best, and I know you will continue with these actions even after the COVID situation. Just a few things about my institution. These are the numbers of examinations in our outpatient clinic. So we have almost 60,000 patients per year. And unfortunately, this might be the reason that one of our colleagues and professor, Dragan Markovic, lost his life due to COVID, because he was the chief of the outpatient clinic and probably he was too much exposed, and he was a great man and great colleague and great teacher. These are the numbers that we do per year, about 400 aneurysms per year. This is the trademark of our institution, and these are some numbers regarding EVARs and TEVARs that we do in the last 10 years. The title of my talk is not my idea. I saw it in the New York Times. This gentleman from Yale was asking, where have all the heart attacks gone? And I'm sorry that I cannot play you the music that you probably know, the very nice song, Where Have All the Flowers Gone? So we are all asking, where are our patients gone? When COVID started, our societies that we are watching carefully published some consensus documents and guidelines. For example, CILSE recommended, as Dr. Kuhel said, to postpone elective cases and be very cautious and only do what is really needed to do. On the other side, American College of Surgeons also said only aneurysms bigger than 6.5 millimeters should be treated, the rest should be postponed. Also, restenosis of the grafts should be postponed. Asymptomatic carotid disease patients should be postponed. And also critical limb patients with rest pain or tissue loss should be postponed if possible. These are the official recommendations that came out in the beginning of the COVID. What was the impact of the global situation? As you can see in this paper, the green is what has changed. As you can see, emergency surgery has not been changed in the worldwide situation, but there was a substantial change in elective and outpatient services. This is a paper that collected some information through the survey. What happened in my institution? These are the numbers compared to the previous years. The same, I did similar thing as Professor Kuhel. So if you can see, the blue is 2019 and the red is 2020. You can see our for the same months, May, June, April, May, March, April, and May. You can see the numbers in elective vascular and elective endovascular procedures and urgent procedure in my institution. As you can see, all went down for 3 or 5 or 6 times. If you watch only aortic procedures, you can see elective aortic procedures gone for 10 times, elective endovascular even more. Only urgent cases were more or less in the similar level. Carotid procedures went down as well, elective, especially endovascular, but in this pathology also urgent cases were less treated. Probably asymptomatic patients that were collected in the cerebrovascular units, in neurological units, were not sent to us as they are usually sending us patients, probably due to epidemiologic situation. I think they treated them conservatively. What is the situation with peripheral occlusive disease that includes also aortoiliac and femoropopliteal? You can see how there was a drop in my institution for 5 or more times for this pathology. So where did the patient gone during the isolation? Actually, in this New York Times paper, you can see different. You can read the different opinions and analyses, and what HEVI and Serbian Society would like to know is if we can reach this conclusion, if we can collect all the data from our countries, from our hospitals, and see what has changed between the previous months for the previous years and these 3 months this year. So I invite you to contact me or guys from HEVI, send us information from your hospital. Soon you will receive survey. If you can fill it, and you can be part of the publication, and we can together come to the maybe more information, where are all the patients gone during this isolation. I also use this opportunity to invite Dimitri Kuhil to join us, because he already collected some data, so we can maybe compare Serbia, Croatia, and Slovenia and see how the things changed and why these things change, and we can just brainstorm about this. What comes next? What comes next is we have to deal all these patients that we didn't treat, and we should wait for the new wave that is coming. So we have to analyze the results. We have to have a safe setup when we start now to treat patients. We have to treat newcomers, but also patients that are on the list. What happened to our patients? We have 134 postponed procedures, as you can see here, aortic, carotid, and peripheral procedures. And we try to call this patient, and you can see that some of them already died, some of them had amputation, and as you can see, 43 patients had progression of the peripheral occlusive disease. What was gangrene now is amputation. What was breast pain now is gangrene. What was claudication now is almost gangrene or tissue loss. We have one rupture. It was a saccular aneurysm of thoracic aorta. A patient died. It was similar patients like Krešimir showed. Nothing much changed. And now we have new patients coming. This is one of the patients that just came. He has a lot of comorbidities, and in our hospital still there was not so much time and space to do intensive cardiological examinations and treatment. The aneurysm was big, so we decided to do EVAR, even though the neck, as you can see, is problematic. So we did endurant regular stent graft, but we managed to do it. But we initially planned to put some endostaplers and to fix this graft. This arrow showed a little bit of endo leak, but this was from last week, so I hope in 1 month it will stop. So in the future, we have to prepare for the new wave. I think we have to change our protocols, materials. we have to think what happened to our patients, especially peripheral occlusive disease patients, especially patients with bigger aneurysm, as previous speakers said. And I think we need to develop and upgrade telemedicine methods to follow our patients during the maybe new pandemic situation and to treat them before they die or before they get worse. Just at the end, I want to update you about some meetings that I'm part of the organization. ESCVS is Padova is probably going to be canceled for the next year, coming soon information. ESVS is going to be held in October as an online congress during the whole October. There will be sessions on Tuesday and Thursday, 2 hours in the afternoon. And our national congress that probably some of you already invited, we will cancel it and we'll leave it for the next year for some better time. Thank you very much.
Thank you, Igor. It was great to hear this data from Serbia. So, as you said, we can expect the second epidemic wave to be here. The only question is when it's going to happen. What do you plan to do in the case of the second epidemic wave? Are you going to be more open to the patient? Are you going to do more elective? Or do you think that you are going to hold this same protocol?
Yeah, when I prepared, thank you, Krešo. When I prepared this presentation, I was brainstorming myself. In our clinic, we are still swimming. As you can see on that slide, we are fighting with the previous patients. We still didn't discuss this, but my opinion is that we have to change the protocol, change the recommendations that were published by CIRSE and ESVS and SVS. So we have to somehow find and treat patients with occlusive disease that are almost, they have severe ischemia. We have to treat patients with AAA maybe a little bit earlier, or we have to find some way to follow them thoroughly, to be in contact with them, and then to treat them if something happens or they get worsened. So we have to find a way to treat patients. I think this stopping vascular service, I think this is the first epidemic we have, so there was nothing else to do. But I think for the next wave, I think we have to find a way to work in some safe way for all of us, for patients and for doctors. But we have to treat some patients, I think we will have to treat.
Thank you, Igor. I agree with you completely. And in our clinic, we are going also to do all preparation for the second wave to continue with the normal program and elective program. So we should move on. The next speaker and the next lecture is about the urgent TIVR, and it's going to be presented by my friend Joško Bulun from University Center Rebra. Joško.
Hello to everybody. Thank you very much for the invitation to this very interesting meeting. I will show you our urgent TIVRs in this COVID era in the last 2.5 months. Indeed, we have more patients than usually. As you can see here, we had 5 urgent patients, 3 patients with traumatic aortic injury, and 1 patient with acute type B 2 patients with acute type B dissections. I would like just to present you 2 interesting patients. First patient was patient with type B dissection, 40 years old patient with hypertension and PTSD. He was interested because he was admitted to other hospital 11 days ago with a short chest pain that moved to the lower abdominal pain and abdominal pain. And in that hospital, because of the inflammatory, or because of signs of inflammation and renal failure, he was transferred to the clinic for an infection. As I said, we had altogether 5 urgent patients, and you can see here 3 patients with traumatic aortic injuries and 2 patients with complicated acute type B dissections. In 2 patients with traumatic injury, we have implanted this new Navion stent graft. So this, I will show you briefly 2 interesting patients. As I tell you, this is the patient with acute type A dissection. He was waiting for 11 days to come to our hospital because he was first diagnosed with the suspicions to the rat bite fever because he had very, very elevated CRP and he had signs of renal failure. He was transferred to the clinic for infectious diseases. And then after 6 days, because of further deterioration of renal function, echo was performed and the acute type A dissection was diagnosed. You can see here from the CT scan, this was the dissection starting immediately on the left subclavian artery and extending all the way down to the abdomen, and especially to the right iliac artery. So this procedure was performed by Dr. Kirschmann and myself. From the left radial approach, we put a Peter catheter, do the angiography. You see here dissection, and then we had problems to enter to the true lumen from the left femoral approach. We did many tries with the Peter catheters. It didn't went. We moved distally again to be sure that we are in the true lumen. Then we tried again. We were in the false lumen. We tried to do it with two PTL's catheter, proximal and distal one. It was again unsuccessful. And at the end, we managed to put this PTL catheter in the short segment of the true lumen. And then with the coronary Jetkins Stride diagnostic catheter and the J wire, after many attempts, we succeed to cross into the true lumen. You can see here. This position was confirmed by the angiography and the blood pressure monitoring, and after that, stent graft 32/200 was implanted with very good result. And you can see here, the procedure took us almost 3 hours.
Joško?
Yes?
Dimitri, listen, in case of dissection, I always enter somewhere on the site where there is no dissection. Yes?
Yes.
And then I use the pigtail without a guide wire, and it goes into the true lumen always. I never had a problem with that. Have you tried that? Because that's a good trick. You don't need guide wire, you need nothing. You form the pigtail in a vessel where there is no dissection, so in iliacs, and then you just put up the catheter. In general, it never goes into the false lumen.
We tried all of that and it didn't succeed.
Okay.
For almost, I don't know, almost 1 hour, I don't know. But at the end, we managed to do it with the wire and the right diagnostic catheter. And the second patient was very interesting. It was a 54 years old man with Burger disease, as you can see, and amputation of the left leg. He had severe motorcycle accident with a traumatic aortic injury, with para-aortic, with mediastinal hematoma, with the laceration in the 6 hepatic segments, with the blood in the abdomen. And what was very interesting, he came just in the middle of the COVID crisis, when in Italy it was disastrous. So he was in the ER room, and all our IC units refused to accept this patient before the COVID tests. Then they called us. We said we will of course put this patient immediately in the cath lab without any tests. So here you can see the CT scans. It was really very extensive aortic injury. This time we did from the left femoral approach. We also had some issues here to cross this traumatic region, especially with this. We did it, as you said, with the pigtail catheter. And after that, very uneventful stent graft was performed. And this patient was done without any heparin. He was transferred directly to the operating theater for the liver surgery. This is controlled CT scan, and he later on was operated also on the orthopedic clinic, and he went home on 28 days. Thank you for your attention. Any questions?
Thank you, Joško, for 2 excellent cases. I think that we all of us sometimes stuck in the dissection. We even with the pigtail without the guide wire. We have almost identical situation with the false lumen, and we tried also to go from the radial artery and to catch, but also as in your case, after 1 hour, we managed to go in the right lumen.
It's very difficult. As Joško said, we did try from what was for sure non-dissected iliacs. We also tried from above after a few few attempts, and I think it was at the end a great case. But Krešo, what actually happened with your case? What did you decide? We saw Igor showed us the similar situation with actually rupture of the thoracic aneurysm. What was your decision?
Well, just to remember shortly, it was so indication, as we comment, was in the gray zone, but we finally decided to do something because we postponed the patient for 1 month, but this time it seems that the epidemic will last for longer than it happened at the end. So regarding the pseudoaneurysm and these points that look to us like potential point of rupture, we decided to do something. And we had our strategy, but I would like to ask the panelists, Joško, Dimitri, Igor, what would you do in your centers with this case? Because we have, as you can see, we have the big pseudoaneurysm that is over the left subclavian artery, and very close is the origin of the left carotid artery.
Yeah, we would do carotid subclavian and TEVR.
We would do TEVR, and then, if necessary, left subclavian carotid bypass.
Dimitri?
I think you first need to see the vessels to the neck, especially vertebrals. If there is dominant vertebral from the left, then I would not cover the subclavia if we would not perform the bypass. However, ischemic of the hand is very unlikely. We close subclavia quite often and not many people have problems. So I think you have to do some imaging before and then you can decide.
So far we had only one case when the bypass was needed next day.
Okay. Tomica, I'm going to show the result. Please continue.
With our next talk, I invite Dr. Sekovsky. He comes from University Hospital Split, which is one of the leaders in endovascular treatment, especially in Aortne in Croatia. They are pioneering these aortic procedures many years ago in Croatia, and Dr. Sekovsky will tell us something about urgent Eva procedures in last 2 months in his hospital in Split. Please, Dr. Sekovsky.
Thank you for your kind invitation. So I'll talk something about urgent Eva procedures in last 2 months in our hospital. Sorry. Okay. So just to be some kind of familiar with our numbers, during the last year we have completed 32 Eva procedures, selective and urgent, and 7 TEVR procedures that were all urgent because we don't perform elective TEVR procedures. This is usually our number in most of the years, so it's some kind of the average number we perform in University Hospital in Split. During this year till 17th March, we had 6 TEVR procedure and 1 TEVR procedure, and the last urgent TEVR was on 2nd of March of 2020. And during this, let's say, lockdown from 17th March to 15th of May, we have only 1 urgent TEVR procedure and 1 urgent Eva procedure. So I decided to show you this, our urgent Eva procedure. It was the 68-year-old male patient with arterial hypertension and hyperlipidemia. He was admitted to our hospital on the 7th of May from General Hospital in Knin because of acute aortic syndrome. He had diffuse abdominal pain, and on the ultrasound it was performed in their hospital, they described aortic aneurysm. So when he was admitted to our hospital, we performed emergency CT angiography of abdominal aorta, where we saw immediately on the native scans that the patient had actually intramural hematoma with some bulging of the outer contour of the aortic wall. And some signs of dissection. So, and the patient was in basically really big pain. So, in the intensive care unit, no matter they tried, they lower his blood pressure and put him on painkillers, the pain didn't stop. So we decided to perform Eva procedure. The diameter of the aneurysmatic sac totally was 6.8 centimeters, and basically the active lumen was not so big. This was our team. We perform together with vascular surgeons. They perform preparation of femoral arteries, and interventional radiologists in our hospital perform the putting of the stent graft. So this was our first angiography scan. We used Medtronics 2S device. We had to put 2 extensions on the right side because we had to use material we had on consignation. So when we put first extension, it was just near the bifurcation. So we had to use another one to be in a good place. And after that, we sealed the left side. Also, of course, with Medtronics graft extensions. This was controlled CT angiography 72 hours after the procedure. We showed that Eva graft was in the good place. There was no signs of any kind of endoleak or something like that. Just to say that in the last 2 weeks, from 15th of May till today, we performed 4 elective Eva procedures and 1 urgent TEVA procedure. So basically, we can say that we are somehow coming back to normal as it was before, let's say like that. I'd like to thank you for your attention.
Thank you, Dr. Sikorski, for great presentation, great demonstration of urgent Eva procedure. Please, could you tell us that is also a question from Q&A. Did you have any problem with availability of the stent grafts? Also, and Dr. Kuhelj, you also did many procedures during this period. Do you have any problem with availability and with the stent grafts because of all the lockdown on many probably transportation and so on? I think we in Croatia didn't feel that problem, but what do you?
In Split, we didn't have that problem. We have some consignation with Medtronic. Now we also starting to use some Cook's device, but usually it's Medtronic. We have some consignation and we have some material that we can make some of these urgent procedures, but we didn't feel any kind of problems with the distribution of material, because if we needed to something to come to our hospital, it was basically in 1 maximum 2 days after the ordering.
Professor Kuhelj, you did lots of patients, more or less like 2019. Did you feel any problem with material?
This is a good question. I did fear that at the beginnings. I checked our suppliers, and stent grafts were really problematic since these are all American companies. However, we had no problems up to now. We have always about 20 stent grafts on stock. However, up to now, there were really no problems with delivery.
Okay. Thank you. We will move forward, and now it's my great honor to introduce Marko Ajduk. He's a great vascular surgeon, one of the leaders in vascular surgery in our country, and also great endovascular operator in field of aortic interventions. And he's also chief of surgery in University Hospital Dubrava. Please, Dr. Ajduk, could you tell us what happened with aortic intervention at University Hospital Dubrava?
Good evening, everyone. I would just like to set up my slideshow that I will share with you. Okay, now I would like to thank the organizing committee of the HEVI for inviting me to this webinar. But I sincerely hope that this is one of the last webinar. I hope some real meeting in the near future. Now, when Dr. Perko, just a second, asked me to say something about what happened to aortic interventions at University Hospital Dubrava. At the beginning, I thought he was joking because he knew that my hospital was completely locked down during this period. We didn't perform any, nor open, nor elective, nor emergency cases in this period, because according to the decision of our ministry, we were set as a primary respiratory center for all COVID patients. So I will show you what we did in this year before the epidemic. Now, we did 10 open AAAs, one EVAR with the Aortic branch endograft. We performed one open thoracoabdominal aneurysm, and at this point I would like to thank a lot my friends from Belgrade. Now we did one TIVA with chimney to a left common carotid artery and one type B dissection. And then epidemic occurred. So at this period we actually did nothing. We were set, as I said, as a primary respiratory center, but we also were supposed to operate on COVID positive patients. However, during these 3 months, there were only 2 COVID positive patients operated in our hospital. One was embolectomy, and the second was some thoracic procedure. So basically, we did nothing. So I would like to thank other hospitals from Zagreb, especially University Hospital Zagreb, and also Sisters of Mercy Hospital for admitting all of our patients during this period. Now, 2 days ago, we started with our program again with about 70% capacity. So yesterday we did our first ERA in this period. That was a patient from we can learn a little bit, something that shouldn't be done. Now, this is some secular aneurysm 5 years ago that was treated with one tubular straight stent graft. That wasn't a good idea, of course, at this position. So everything was all right for the next 5 years. This is the follow-up 2 years after the procedure. The stent graft was more or less okay, but even in this images, we can see that there is some deformation of the aorta, the elongation. So it was a matter of time when this stent graft won't seal properly. So that happened actually at the February this year. This is the patient. The patient developed type 1B endoleak. You can see it on the both slides. So we did what we actually had to do at the first place. We put another stent graft that covered all the old stent graft and extended to both common iliacs. So this is our first patient is in this post-COVID period. So I hope we'll start working as usual from now on. Now, what will happen, we can't tell. But it will largely depend on the epidemiologic situation. I have spoken with several epidemiologists, and they all think there will be a second wave, but this second wave shouldn't be so dramatic as this first wave. And there are some predictions that our infected clinic will be able to cope with all those patients. So I really hope that during this second wave, my hospital won't be again only a hospital for respiratory patients. And of course, until there is no effective vaccine, we can't sleep quietly. So only a good vaccine will solve the problem with the COVID patients. So I thank you for listening to me, and I wish all us good luck.
Thank you, Dr. Aortic, for sharing your experience. How was it like to work in University Hospital Dubrava? I have one short question for you. What do you think? What is the preferred option for the all patient during COVID era in this indication for acute ruptured aortic abdominal aneurysm? Or is it more forwards to intervention and EVA, or is it open surgery? Or it doesn't matter what is, if it's an epidemic or not?
Actually, we did prepare all protocols for these situations. Mostly we backed up on American College of Surgeons and the Royal College of Surgeons recommendations. So I think the first line should be, whenever it's possible, endovascular approach for those patients.
Yeah. Okay. Thank you very much. It was a great presentation. Thank you for participating in our webinar this afternoon. I would like to ask my dear colleague and friend, Dr. Stambuk, what actually happened with this patient with a large pseudo aneurysm in thoracic aorta?
Well, thank you. I know that this patient, for all of the panelists, is not maybe something special, but I think that this is the teaching patient for all other participants, and I think that the take-home message would be that this patient may be in the next epidemic wave. We should not postpone, but we should keep the courage and to treat these patients. So, as panelists said, we decided to do carotid subclavian bypass to this patient. Sorry, for reason that this left subclavia was included in the pseudoaneurysm, and the neck of the rest of the ascending aorta, or the beginning of the arch, was too short to avoid endoleak. So our vascular surgeon, Dr. Škopljanac, he made carotid subclavian bypass, and after that we put one Valiant Navion 4040, and I think that the final result was good. There was no endoleak. We have the optimal position of the graft with, I think, good proximal position. We have the anterograde flow through the left subclavia, and you can see the functioning bypass to the subclavia here, and the anterograde flow through the left carotid artery. But there is no endoleak, and I think that we had complete exclusion of this pseudoaneurysm. Tomica?
Excuse me. I think it's a great case, great demonstration of collaboration with vascular surgery and interventionalists. And I just wanted to ask you, what was the feel like handling with this new stent graft? Is it precise? How do you feel it in comparison with the old one, Captivia?
Well, Navion is excellent graft. I think that the previous Valiant also was the excellent graft, but Navion have some improvements. It's a very friendly user, and I think that in Medtronic grafts, this hydrophilic coat is the key. You can go sheetless, and it's very, very easy to position it even over the very angulated aortic arch.
Dr. Bulum had also one excellent case, and he was very, very satisfied with this new graft. Okay, Krish, I think we did a good job with this webinar today. What do you think?
I think that it was an excellent webinar. I want to thank you to you and to all participants, to all panelists. I think that the messages for the next months are very clear. We should keep doing our work. And for conclusion, Tomislav.
Thank you for all participants, all the speakers. I think it was very interesting. I think we should carry on. We learned something from this first epidemic era, and I think in the next, probably, I think maybe it will not be so big problem with second wave, but we must be prepared. And I think we will manage better than first wave, although in Croatia and all the region it was not so bad. Thank you again, guys, all for participating in our, I think it was very interesting webinar, and see you soon in more actions by HEVI. Thank you, guys.
Thank you all. Bye-bye.